In my talk, I will touch upon several topics related to novel medical therapies for the failing Fontan. In Groningen, we started to do Fontan surgery in 1975. And a few years ago, we were curious about the long-term outcome of this intriguing population. At that time point, we had about 200 patients in our database, and we were able to demonstrate that the survival improved over the decades. However, we were a little bit surprised that after exclusion of the patients who died within the first 30 days after the Fontan completion, we could not demonstrate a survival benefit for the late mortality, suggesting that the Fontan circulation has a limited lifespan in itself. And this attrition of the circulation is reflected by several components. First of all, the diminished exercise capacity, here presented as a peak VO2 in relationship to the time since Fontan surgery. Secondly, a lot of our patients suffer from atrial rhythm disturbances related to the right atrial enlargement and surgical scars. And a lot of our patients suffer from liver cirrhosis, and that is not related to the alcohol in this bottle, but to the Fontan circulation, and these patients are at risk for hepatocellular carcinoma. And finally, the Fontan patients have high systemic venous pressure by definition, and this is related to ascites, edema, and pleural effusions, often in combination with protein-losing enteropathy, which is present in 5 to 15% of all Fontan patients. So, listening at this list of problems, it is difficult to stay optimistic, but there are some rays of hope, and I think if we want to make further steps, we have to think outside the box. The box we use for patients with biventricular hearts. Of course, one could think about takedown of the Fontan circulation, takedown to a bidirectional gland or systemic to pulmonary shunt. And we were curious whether this was done before in Europe. So we collected data from congenital heart centers in Europe, and we collected data of 38 patients. During a mean follow-up of almost 7 years, we saw that 15 patients died. That's about 40%. And 2/3 of these patients died within 30 days. Most importantly, the time between the Fontan completion and the takedown surgery was very short. It was within 1 year. So it appeared that this surgical strategy was done before because of early Fontan failure, and whether this is a realistic option for late Fontan failure is unknown. In the one of the ultimate surgical options is, of course, heart transplantation. And in the same study, we collected data of 50 patients with Fontan failure who got a heart transplantation. And here you see the Kaplan-Meier, and after 10 years, there was 60% survival with endpoints of mortality and retransplantation. I think we are doing now better in terms of survival after heart transplantation, but the reality is that there is an enormous scarcity of donor organs, especially in the Netherlands, and we are overflowed with failing Fontan patients. So for these patients, it would be nice to have a bridge to transplant, maybe an artificial pump. And one of our colleagues from the USA, Mark Rothfeld, and he will talk later, is pretty confident about this Fontan blood pump that forces blood through the lungs. And I saw on his website that it is currently in a fundraising state, but it also raises our attention, and we are very curious how it will end. There are also pioneering surgeons who try to treat PLE. Here you see a schematic drawing of the Fontan circulation with, in green, the lymphatic vessels, and the lymphatic vessels enter the systemic venous vessels at the high pressure point. And this is one of the causes for the development of PLE. And we have seen it before. Victor Raska rerouted the innominate vein to a low pressure chamber, the common atrium, and by doing this he decompressed the thoracic duct, and there's also a concomitant increase in preload. It has positive effects on albumin, but long-term outcome was not described in this article. But the music doesn't come only from the surgeons. There are pharmacological trials trying to ameliorate the high pulmonary vascular resistance. And our group demonstrated an adverse pulmonary vascular remodeling in the lung tissue of Fontan patients obtained after autopsy. And in the top panel you see the lung vessel of a control specimen, and in the lower panel you see the vessels of Fontan patients. And the difference is striking. You can see a thickened vascular wall with reduced lumen area, and this has serious consequences for the pulmonary vascular resistance. So it seems to be reasonable to treat those patients with pulmonary vasodilator therapy. There have been several trials with bosentan, sildenafil, and iloprost, and these trials used exercise-related endpoints. Looking at the bosentan trials, there was one study, the well-known Temple trial, reported in Circulation 2014, who described a small increase in exercise capacity. Also, iloprost showed some improvement in exercise capacity, but most of the data come from sildenafil, and not all studies were positive, but there were of the studies reported improvements, for example, in exercise capacity, exercise hemodynamics, and ventricular performance. Recently, the effect of ambricetin on exercise capacity was reported, and also here there was a small increase in the oxygen consumption reported. Tadalafil was investigated in a study from Iran for a duration of 6 weeks in 15 patients, and tadalafil was shown to have a significant effect on myocardial function, exercise performance, and functional class. And more NICE is underway. Recently, a phase 1/2 trial was reported and conducted by the Pediatric Heart Network in 36 subjects, and this study was designed to evaluate the safety and pharmacokinetics of sildenafil. and it was concluded that sildenafil was well tolerated, and there was a suggestion of improvement in myocardial performance. So probably we will hear more about this trial in the near future. But I have to temper all too optimistic feelings because these were small trials, effect sizes were modest, and I think more placebo-controlled trials, larger trials, are needed with a longer follow-up. And we have to think about the reason why previous studies were positive. The mechanism and the clinical significance are not clear yet. Was it only the increase in preload that causes the positive effects? In that case, a faster solution could also be possible by a transcatheter fenestration described in 19 children with failing Fontan, and where an improvement in cardiac output, pleural effusions, ascites, and PLE was reported. But don't forget the simple interventions. I was impressed by the effects and the simplicity of an intervention with inspiratory muscle training. Only 30 minutes per day during 6 weeks resulted in 23 patients to a muscle increase in muscle strength and a small increase in cardiac output and ejection fraction. And it is also timely to think about the selection of our patients for Fontan surgery. There are among the population with univentricular hearts subpopulations who might be better off without Fontan circulation. For example, the patients with a double inlet left ventricle with a pulmonary stenosis, you could see the transplant-free survival, and the median age at death was 53 years old. That is high as compared to a lot of our Fontan patients. So also the favorable streaming patterns in this population causes a mean oxygen saturation that was 86% is quite acceptable. So in the meanwhile, we are getting better for preparation of difficult operations. 3D printing might be helpful. Multimodality imaging can guide us through difficult percutaneous interventions. 4D flow MRI learned us a lot about the physiology of the Fontan circulation. There are promising anticoagulation trials, and new interventions are reported. For example, the study by Ratnayaka in JACC this year. So in conclusion, I hope that the treating physician got the feeling that this field is on the move, and there are novel therapies underway, and I hope that we will join forces to achieve a better quality of life and better life expectancy for these unique individuals. Thank you very much for your attention.
Thank you. We're open for questions. Let's do a quick survey here. See if I can phrase this correctly. It's transparency's sake. I am not an adult congenital heart specialist. I'm a pediatric cardiologist, and probably more so even a fetal cardiologist. But I'm curious, within the group here of adult congenital heart specialists, how many of you routinely place your adult Fontan patients on some form of a pulmonary vasodilator? Routinely. Okay. All right, how many of you do so selectively, say for patients who have particular issues or challenges? Okay, that's the vast majority. All right, how many do not believe that pulmonary vasodilator therapy have any impact whatsoever? Okay, maybe a shy hand here and there, but okay. All right, Rarity. All right, that's interesting. Thank you. Yes,
so,
sir.
Given this, I'm Ari Cedars, and I'm at Baylor in Dallas. Given that you are a pediatric cardiologist, I would ask your opinion on pulmonary vasodilators in the pediatric population early after Fontan to hopefully prevent pulmonary vascular changes that lead to the elevated pulmonary vascular resistance that ensues, because all of these are blocking signaling pathways that have been demonstrated to cause pulmonary vascular fibrosis.
Sure, it's a fantastic question. I would extend it even further to say, can we alter the substrate even prenatally in some way to create a vasculature that best accommodates, passive venous flow, something nature never intended us to have, right? So you could extend it that far. But the answer is we don't know whether we can do that, but I will tell you, and I'm going to show you some data in my talk later on, about 10% of our population at our institution is now on a pulmonary vasodilator, and that's pretty much all ages. And if you look back, even 5 or 6 years ago, it was much less than that. I can't give you a quantitative answer, but I can tell you that there is a growing number of patients, in particular ours with hypoplastic left heart syndrome, who get started on sildenafil after a Glenn procedure if they have persistent effusions or have any sort of difficulties and such, and then we'll continue that typically even after the Fontan. So it's an intriguing question, and one I think we have to be careful about because, as the train has left the station here, it's almost the enalapril phenomenon, that we had years ago. We may not be able to study this properly if we begin to take this on without any data. I think the FUEL trial, the PHN-sponsored trial looking at sildenafil, should give us some good data and some guidance.
Yeah, I agree with the train left the station comment. I think a lot of the benefits that could be enjoyed from a lot of these therapies are kind of too little too late when we're starting to employ them in adult patients that are already failing. So.
I'd add an additional plug in there for the FUEL trial as well too. Dr. Goldberg and Dr. Paradon are leading this out of CHOP. This is a Pediatric Heart Network sponsored study that is looking at adolescent patients and the effect of PDE5 inhibition in exercise performance. So if any of you are interested or have patients that might potentially be interested, you can go to the Pediatric Heart Network website and you can see centers that are enrolling patients. There are, I don't know exactly how many centers we're up to now, but quite a few across the country. So more than likely either your center's enrolling or there are centers that are close by you that are.
So my question is to the speaker, but also for the panel, please feel free to chime in regarding intervening on a failing Fontan, especially in the cases of what we like to call the Fontan failure phenotype 3, which is driven by liver failure. What would be your thought regarding isolating the liver from the Fontan circulation and reattaching it to the systemic circulation, almost in a Kawashima kind of situation? Because we've had a limited experience with that at Emory. We had 3 patients who underwent that kind of modification with, moderate success. But
it's an interesting question, but I don't have the experience with such a case, so I think I cannot comment on that.
Yeah. Christian Brizard has similarly described this, and O'Brien Kogan described it a few years ago as well. The way I look at that particular maneuver is it's a matter of picking your poison as to how you want to proceed. Sure, it might alleviate in a temporary manner the issue of venous congestion and perhaps lymphatic congestion in the liver and maybe be an acute treatment for PLE. But long term, I think what we've learned from our other experiences of hepatic vein exclusion type Fontan, that if you leave the liver at a low pressure, ultimately you'll develop venous collaterals and likely progressive cyanosis. Now, what the time course of that is and how significant that will be, I don't think we know. Perhaps some of the Kogan and Brizard patients will define that for us, but that's one of the concerns.
Sorry, Mike Connolly from Calgary. If you are putting people on pulmonary vasodilators, such as sildenafil or ambrisentan or something like that, do you believe the effects that you're getting, if you're getting any effects, are actually due to pulmonary vasodilation, or do you think it's the systemic effects that are actually beneficial?
I think that's an excellent question. When you read those papers, they all say that it's probably the preload that will increase and the stroke volume and the cardiac output, but the systemic effects are not investigated as far as I know.
That's my thought as well. I think
Yeah.
we label them as pulmonary vasodilators, but that's only a part of the effects, and they have really quite profound systemic effects as well.
Yeah.
Thank you.
Yeah, just to add a comment to that, there's no doubt that phosphodiesterase 5 is well distributed within the right ventricle. Data to demonstrate that it's upregulated in the right ventricle in patients with pulmonary hypertension. And Shelley Miyamoto has done some work from Denver showing that there's a significant degree of upregulation in the single right ventricle patients. So there's no doubt that there's likely an impact on the systemic effects, particularly in the ventricle. But to what degree is it pulmonary vasodilation versus the pump, I think is hard to discriminate just yet.
Thanks.
Hi, Jamil Abelhosen from UCLA. Great session so far. This may sound a bit controversial, but I don't know if we have the luxury in this population of waiting until we have really great prospective randomized data. And I think if you would have taken a poll 5 years ago or even 3 or 4 years ago at Skamania, because we debated this exact topic about should all Fontan patients be on pulmonary vasodilators, yes or no, you would have found that a lot of hands would have gone up saying, no, we wouldn't put them on pulmonary vasodilators. So there's certainly just by that poll, there's certainly a change. And there's a growing body of evidence. And I would say that in such a high-risk population with such poor outcomes, we should be looking for reasons not to put them on pulmonary vasodilators as opposed to reasons to put them on pulmonary vasodilators, especially given the growing body of evidence. And yes, I agree, it may not all be at the pulmonary level, but certainly the majority of the work that's being done shows safety and does show that there is at least a trend towards efficacy in this population.
Yes, I totally agree with this statement. Yeah.
I would add just a point to Jamil's statement is for all of the folks here that take care of adults with congenital heart disease. I think many of the times when we end up seeing these patients in clinic, they're sick and they're symptomatic, and sometimes they're beyond the point of being able to be evaluated for transplant and other options. And so you have to try something to be able to see if they feel better, whether or not you have data, hard data or not. You're forced with making that decision of trying something to be able to help them with their symptoms.
Of course, you stay with your back against the wall, and then you try things. Huh?
Perhaps time for just one more quick question.
Peter Eriksson, Gothenburg, Sweden. My question is for the pediatrics. Do we have enough information in order to refine who's going to have a full Fontan and who's doing better with just a Glenn and stay?
The short answer is no. We don't just yet.
Not even a clue?
Well, certainly some clues in the sense of, part of your question relates to the fact of whether there's a unique anatomical setup that might allow for some degree of antegrade pulmonary blood flow. So I think there is an opinion that exists that perhaps leaving a Glenn with some antegrade flow might get you the right balance for a sustained long-term solution. But taking patients like those with hypoplastic heart syndrome where that's not possible, leaving them as a Glenn will typically result in the development of pulmonary arteriovenous malformations and progressive cyanosis. So you have that balance versus the sequelae of the Fontan. So I don't think we have an answer to that just yet.
Great, wonderful. Wonderful talk and great questions. Thank you so much.